Hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenour, and today I'm joined by gastroenterologist Dr. Shelton McMullan. Today is National Dress in Blue Day, so we're both wearing our blue to increase awareness of the second deadliest cancer in Maryland, colorectal cancer. Today we'll be discussing colorectal cancer risks, prevention, and why early detection is so important. So give us a like to let us know you're watching, share this broadcast with your friends, and if you have any questions, please ask them in the comments below. Before we get started, Dr. McMullen, would you mind telling our audience a little bit about yourself and your background?
Sure, Sarah. Thanks for having me. I am a gastroenterologist here at MedStar Franklin Square Medical Center, and I've been here for a little bit over 3 years. I did all of sort of my training in gastroenterology at MedStar Georgetown University Hospital in DC. So I did that training for 3 years. And prior to that, I did my residency at George Washington University, also in DC. And I also went to med school there. I'm considered sort of a general gastroenterologist in that I address a lot of different, really all GI issues. So that's anything including the liver, the pancreas, the entire gastrointestinal tract. So that's the esophagus and the stomach, the small intestine, the large intestine. So I see people for a variety of things: irritable bowel syndrome, liver disease, inflammatory bowel disease, including Crohn's and ulcerative colitis, and acid reflux, sort of everything.
A little bit of everything. Well, thank you again for being here and joining us today. So let's get into the questions. First of all, let's start off. What exactly is colorectal cancer?
Colorectal cancer is cancer of the colon, which is the large intestine. The large intestine is it's sort of the bottom 6 feet of our intestinal tract. The most common type of cancer is something called adenocarcinoma. The way that cancer sort of develops is a precancerous polyp develops. A polyp is an abnormal growth that we sometimes find in the colon. There's no real rhyme or reason as to why we develop these polyps. But a precancerous polyp sort of progresses along the line towards cancer. And then you develop an advanced precancerous change that we call dysplasia. And then ultimately that turns into colon cancer. The thought is that generally a precancerous polyp, once it develops, the timeline in terms of that ultimately turning into colon cancer is about 10 years. So it's not something that typically happens overnight. Granted, that can vary. Nothing with our bodies, fits into sort of a perfect box, but generally that's sort of the course. Colon cancer in men, sort of worldwide, is the number 3 most common cancer that we see. It's the number 2 most common cancer that we see with women. And so globally, it's the second most common cancer in the world. In the United States, just to sort of put things into perspective, the average, for a person who has sort of average risk for developing colon cancer, the lifetime incidence is about 4%. And so, for the average person, about 1 in 25 Americans will develop colon cancer at some point in his or her life.
Wow, that's incredible. That's amazing. And so going along with that, what are some of the risk factors that come with colorectal cancer?
So the biggest risk factor is sort of what's called inherited susceptibility. In other words, there are some people who have genetic syndromes that increase the risk for colon cancer. There's something called Lynch syndrome. As another example, there's something called familial adenomatous polyposis. So for people who have those syndromes, that's the biggest risk. In terms of just general risk, we see colon cancer a lot more in men as compared to women. The mortality, in other words, ultimately the number of men that die from colon cancer is about 25% more than what we see with women. So it's certainly seen more in men. In general, colon cancer is rare for age less than 40.
Okay.
So once we reach 40, we see the risk between the age of 40 and 50 certainly go up progressively. In general, in the United States, colorectal cancer is decreasing, but it is really important to note that the prevalence of colon cancer, the amount that we're seeing it for those of us who are less than 50 years old, that's actually increased by 2% every year between the years of 2005 to 2016. So, a simple way of looking at that is basically over the last 15 years, we are seeing colorectal cancer found more in people less than 50 years old, which, that's really important to note. We're not sure why that is. Maybe it's because people are being screened more, but sort of the reason for that has to sort of, be elucidated. So yeah, an inherited, a syndrome that you've inherited certainly places you at increased risk. Being a man increases your risk as compared to being a woman. Age, so once sort of you're over 40, we start seeing the risk going up. We do see colorectal cancer a lot more in African Americans. Okay. We're not sure exactly why that is either. We see it about 20% more in African Americans as compared to Caucasians, for example. So those are sort of the big risks that we think about. Some people are more at risk than others. People who have inflammatory bowel disease are at increased risk. The two types of inflammatory bowel disease are something called ulcerative colitis and also Crohn's disease. For anyone, if you have a screening colonoscopy and you're found to have precancerous polyps, that increases your risk. If you've ever had colon cancer, of course, that's going to increase your risk for having it again in the future. Something important to note is if you have an immediate family member who has ever had a precancerous polyp, that is what we call advanced. And so precancerous polyps, not to sort of get into like the weeds here, but most precancerous polyps they're called adenomatous polyps, tubular adenomas. Some polyps can be bigger than others. Specifically, some polyps are a centimeter or bigger in size. Some polyps are called villus adenomas. Some polyps have more advanced precancerous changes. So sometimes, it's fairly common for some of us to know, hey, my dad had precancerous polyps, or my brother was found to have precancerous polyps. If you do a little bit of digging and you ask, your father or your brother, if we can ever figure out if those polyps are what are considered to be advanced, that places us at increased risk for colon cancer. And when we talk about immediate family members, that means your parent, that means a sibling, that means a child. And sort of outside of that, a lot of people come to me and they say, my grandfather had colon cancer or my uncle did. Am I at increased risk? They might be at somewhat increased risk, but the increased risk is not great enough to warrant, having, they don't need to have a screening colonoscopy any earlier than someone whose dad had it or whose, brother had it. Okay. And just, sort of staying on that topic, let's say, like if your father had colorectal cancer, we recommend that you have your first screening colonoscopy 10 years before he was diagnosed. Let's say if he was diagnosed at age 60, you would have your colonoscopy 10 years before that. So when you're 50, or you would have it at age 40, whatever's earlier. Okay. But you would need to get a screening colonoscopy earlier because of that immediate family history.
Right.
There are also other things that are thought to increase the risk. Just as examples, some people who have had kidney transplants are at increased risk. Some people who have a condition called acromegaly, where you produce more growth hormone that is normal. Okay. Those are thought to increase the risk a little bit. There's also there are a lot of questions about, there is some thought that as an example, chronic alcohol use increases the risk. Obesity increases the risk. We've heard a lot in the media recently about, regular eating of red meat, of eating processed meats. I know that I eat a lot of deli meat and have my whole life. I think a lot of us can fall in that boat. There's some thought that maybe that increases the risk for colon cancer. On the flip side, there are also a lot of studies that do not show that increased risk. So, diabetes is thought to maybe increase the risk, but those are not definitive. We can't say for sure that those other things increase it. So, there are a lot of possibilities out there. I think the things to focus on are, being male, being an African American, certainly that immediate family history is important. Those are sort of the main things to think about.
Okay. Well, thank you for explaining all that. Yeah, it sounds like you said, those are the most important things, but there's other factors that could possibly play into it. And we'll talk about screenings a little bit later, but I think, with how prevalent you were saying it was a little bit earlier, that shows how important it is to make sure you get your screenings. And like I said, we'll touch on that earlier or later. So my next question is, can colorectal cancer be prevented?
So there's nothing really to prevent colon cancer. I mean, I think what you and I are stressing today is the importance of screening. There is some thought, and again, there's studies out there, there's no proof though of being able to prevent it. There is some thought that, having a diet that's high in fruits and vegetables can be perhaps preventative. There's been some thought that getting enough folic acid or folate in what we eat is important. There was some attention brought to the idea of taking aspirin on a regular basis, or taking what are called non-steroidal anti-inflammatory drugs. Those are things like ibuprofen, which is Advil, naproxen, which is also called Aleve. So there was some thought that perhaps that decreases the risk. That's not proven, and so that remains to be seen. Another example is for women who no longer get their period, taking estrogen and progesterone on a regular basis is thought to maybe be somewhat preventative. But yeah, this sort of the short answer for that is no, there's nothing really to prevent it. Again, the really important thing is just to make sure that you're getting screened appropriately. So that's the answer for that.
Right. And so we talked about risk factors, but is there any specific warning signs of colorectal cancer?
Sure. The takeaway from today is often the way that colon cancer typically presents is people will present with symptoms. Colon cancer, once it's advanced, if you have a mass in your colon, if you have a big colon cancer that's sort of blocking the passage of things through the colon, that can certainly produce symptoms. The most common symptoms that we see for people who ultimately are found to have colon cancer are bleeding. And so, often people will come to me and they'll say, hey, I've noticed blood, when I've gone to the bathroom for the last 6 months or something. So often we see bleeding. Often we see a change of bowel habits. So, going to the bathroom less than usual. Difficulty with producing a bowel movement, a lot of straining. And colon cancer presents in different fashions. A colon cancer that is found sort of more towards the end of the colon is more likely to produce a symptom like difficulty with passing stool and straining. We see that colon cancers that exist more sort of towards the beginning of the colon might have more of a propensity for bleeding. Sometimes people are found to have new iron deficiency, and so they have regular blood work with their primary care doctor, and they're found to have maybe a low blood count, which is, we term that anemia, or they're found to have, a low iron level. And sometimes we see that with colon cancer. Sometimes colon cancer will bleed sort of off and on very slowly, and people don't necessarily see any blood loss. So they don't see blood in their stool. They don't really see a change to the stool color. Sometimes people present with abdominal pain. Abdominal pain can be caused by a million things. So of course that's extremely nonspecific, but sort of the takeaway is, the value of a screening colonoscopy, a colonoscopy done when a person is not having symptoms, is that ultimately you might find some precancerous polyps. A polyp generally is not going to cause any symptoms. And so there are a lot of people out there who have precancerous polyps and they would never know that they have them because they don't have symptoms. Right. The benefit of a screening colonoscopy is if you are found to have these precancerous polyps, I take them out. So they're removed. And, with that removal, that takes away the risk for them to potentially turn into cancer. You would never know that you had these polyps if you didn't have a colonoscopy. So that's really the benefit of having a screening procedure.
Right. And that, kind of answers and goes into my next question, which is why is it important to detect it early and what steps can you take to detect it, which, you explain screenings and, the importance is to stop it from possibly becoming something worse,
Right. Yeah.
So I'll take a minute now to pause and say, if you're just now joining us, thank you for tuning in. We're talking with gastroenterologist, Dr. Shelton McMullan. We're talking about colorectal cancer risks, prevention, and why early detection is so important. We have a lot more to talk about, so stay tuned in. Share this broadcast with your friends and give it a like to let us know that you're watching. And of course, if you have any questions, please leave those in the comments below. So my next question for you is, we've talked about screenings and the importance of them, but what are the guidelines for getting a screening?
Sure. So for a long time, it's been recommended that African Americans start screening at age 45. Mm-hmm. And again, the reason for that is that the prevalence of colorectal cancer in African Americans is certainly higher than other ethnic groups. So it's been 45 for African Americans for a really long time. Mm-hmm. For a long time, it's been age 50 for others. Since 2018, the American Cancer Society has recommended age 45 for everyone. Just recently, new guidelines came out in October of 2020. So, 5 months ago, from the U.S. Preventative Task Services Force. And that was to start at age 45. So more and more, we're seeing this recommendation to start at age 45 for everyone. I think that the reasoning behind that is that a lot of studies have shown that the prevalence of finding precancerous polyps in people who are 45 is really the same as what we find with people who are 50. And so, if we're finding these precancerous polyps sort of, equally in 45-year-olds as with 50-year-olds, it makes sense to recommend that everyone starts the screening at 45. So that's a big change. Up until recently, I was really just, I was telling people that it was still pretty much 50. And a lot of that had to do with sort of insurance coverage. Okay. But I found more and more that I think most insurance companies now, they're essentially forced to cover you at age 45. It's fully accepted now that 45 is the age to start. Okay. So that's the recommendation. And that, again, that goes back to someone with average risk, right? Mm-hmm. So for, this is not apply to people who, whose father had colon cancer, or, for people who have Crohn's disease and things like that. Right. So for the person at average risk, 45 is the age to start.
And then for people at higher risk, I know you said if it's a relative, you would do it like 10 years before they were diagnosed. Is there any other sort of guidelines for people at higher risk?
That's still the same. Okay. So, immediate family history. So if one of your parents had colon cancer, if your brother or sister was diagnosed with it, if you had a child who was diagnosed, you would get your first screening procedure 10 years before the age at which that person was diagnosed, or at age 40, whatever comes earlier. And then going forward, what's important to realize is going forward, you should be screened more common than the average person would be. You know, for a person at average risk, he or she gets that first screening colonoscopy. Mm-hmm. If no precancerous polyps are found at that first procedure, he or she does not, you don't come back for 10 years.
Okay.
But if you have an immediate family history, so let's say your dad had colon cancer, you should have a screening colonoscopy done every 5 years, at least until the age of 75.
Okay.
And that's without fail. Now, once we get to age 75, there are no guidelines to say that past the age of 75, you should get a screening colonoscopy at any certain interval. If you're between age 76 and age 85, that's really an individualized, conversation that you have typically with your primary care doctor about whether or not you need one. Now, of course, that's different if you're having symptoms. If you're at any age, if you're 25, if you're 75, if you're having symptoms, if you're seeing blood in your stool, that's a different scenario. That very well should probably be evaluated with a colonoscopy. But for those of us who are older than 75 and we're not having any symptoms, you really just you'll have a colonoscopy performed if the benefit of undergoing it is thought to outweigh the risk.
Okay.
And that's the case for a colonoscopy at any age. We're only doing this, if the benefit of the procedure is thought to outweigh the risk.
Right. Okay. And now, so are there different types of screenings, tests that can be done, and which, is there a certain test that's better for a certain situation, or which one would be best for, is it an individual decision for the patient and the doctor?
Yeah, there's certainly many options. There are a lot of different ways to screen for colon cancer. There are non-invasive means, that's essentially meaning submitting a stool sample. Mm-hmm. And there are different ways to do that. I know I've seen a lot of commercials on TV recently for something called Cologuard. Cologuard it's a fecal immunochemical test, FIT, with DNA. So what that looks at is it looks for blood in the stool, and then it also looks for genetic material that can be associated with what are considered to be advanced precancerous polyps, mm-hmm. and also genetic material that's related to colon cancer. So, what you do with Cologuard is a little kit comes to your house, and you put a stool sample in the mail, and then that's tested. There's something called a guaiac fecal occult blood test, and that the right way to have that done is a stool sample. 3 different stool samples are sent for analysis. That looks for blood in the stool. There's something called just a straight fit test, which is also, that necessitates providing a stool sample. So those are all the non-invasive ways to screen. There's also some imaging. There's something called a CT colonography. It's also called a virtual colonoscopy. And the way that you prepare for that is you drink a bowel prep, just as you would for a colonoscopy. That's essentially a CAT scan. And so I think most of us have heard of CT scans. It's just a special type of CT scan. Those are all of the non-invasive ways to screen for colon cancer. The invasive way is colonoscopy. Colonoscopy is still the recommended way to screen for colon cancer. The benefit of colonoscopy is that it's therapeutic. It can be, meaning if I do a colonoscopy and I see something abnormal, if I see some inflammation, I can take little tissue samples. If I see polyps, I take them out. So that's what I mean by therapeutic. In other words, if I see something that's abnormal, right then and there at the time of the procedure, I can deal with it.
Okay.
And it's diagnostic as well. Colonoscopy is the only way that I can see your colon close up. Mm-hmm. These other tests are not able to do that. An important thing to remember is that if any of these other tests are abnormal, so if Cologuard comes back as abnormal.
Mhm.
If the stool test that looks for blood is abnormal, if the CT colonography is abnormal, you then need a colonoscopy. So, the takeaway is that the gold standard still remains colonoscopy.
Mhm.
And I think that's going to stand true going forward. I don't think, until we have something to replace that's as good and effective as colonoscopy, that's going to remain the gold standard. The sensitivity, in terms of finding precancerous polyps, in terms of finding colon cancer, the sensitivity is highest with colonoscopy. It's still the best thing that we have out there.
Mm.
The sensitivity, the effectiveness of Cologuard in terms of sort of raising a flag for possible colon cancer, that's pretty close to colonoscopy.
Mhm.
Again, if Cologuard's positive, you need a colonoscopy then at the end of the day. So those are sort of all the options.
Okay. And so speaking of colonoscopies, let's talk about that a little more. I know some people are hesitant to get one done. Can you explain the process of a colonoscopy, the prep before and the actual process, and kind of talk about the reasons why people are hesitant to get one and why they should still get one though?
I think people are hesitant because they might hear about the prep, thinking that the prep is hard to take.
Mhm.
The prep it's liquid, and there are a lot of different options. In the past, what was most commonly given was a huge jug of liquid. And it was a lot to drink for a lot of people. Everyone's different. Some people really struggle with the prep, understandably. If you have to drink a lot of liquid, for some people that's just hugely bothersome. But there are a lot of options now. I tend to give a prep that's a lot less liquid than what was previously given.
Okay.
But there are a host of things. I most commonly give Miralax, which is a common laxative that likely a lot of us have heard of, and you mix that with Gatorade. But there are other options. There's something, for example, called Suprep. There's something called Clenpick, Movie Prep. Some of these options are really low volume, and so for a lot of people that might be preferable. It's a lot less liquid to drink. But the way that we prepare is that you start drinking a prep typically the evening before the day of your colonoscopy. So we have found that drinking half of the prep the evening before and then drinking the other half early in the morning on the day of the procedure is most effective in terms of cleaning our colon out really well. The whole goal of a prep is it's going to make you have a lot of bowel movements. The idea is that it's cleaning the stool out of your colon. And so, very honestly, it's not going to be the greatest night of sleep that you've ever had, right? You're going to be going to the bathroom a lot.
Yeah.
That's to be expected. That's the goal. But that's the hard part. If there is anything that's sort of hard in terms of colonoscopy, it's typically not the procedure itself. The procedure tends to be pretty seamless and straightforward. So if there's anything that's maybe hard, it might just be the prep. Most people do really well with it though. So, in addition to drinking that prep starting the evening before the procedure, that entire day before the procedure, we have you stick to clear liquids. And so that entails things like light colored Jello, chicken broth. You can have coffee if you don't use creamer or milk. But if you're going to have a colonoscopy and you see me to talk about it, before you leave my office, I give you really detailed instructions. You have a list of all of the stuff that you need to avoid. You've got a list of everything that you can have. Most people end up being fine. Remember, it's one day.
Right.
That, let's say your colonoscopy is on a Monday. When you wake up Sunday morning, that's when you stick to that clear liquid diet. But it's a 24-hour period of time. Most of us don't really like that much, but we end up being just fine. So yeah, I think that the hesitancy regarding the procedures may be that, the preparation. I think some people worry about, hey, do I need to stop my medications? I'm diabetic. Do I need to, hold my insulin? we give you instructions about all of that. Specifically for those of us who are diabetic, typically, yeah, you're going to take less insulin. Most of our medications, it's recommended, are held the day of the procedure. So, if you're used to taking your medications in the morning, you would not, but that varies. For those of us, for example, who have high blood pressure, you would continue your high blood pressure medication. So all of that's spelled out in detail. Again, all of the paperwork that you get is really detailed in that regard. I tell everyone, what I want you to do is really do your best in terms of following the bowel prep instructions. And if you do that, you're doing your part. You're doing everything you need to do. At the end of the day, sometimes, despite following directions, a person will still have a fair amount of stool in his or her colon.
Mm-hmm.
That can't be helped though. If you follow the directions, there's no way to prevent that. And that's really nothing to worry about. Sometimes a colonoscopy has to be rescheduled if the bowel prep is insufficient, but that's not overly common for sure. So yeah, I think that's what people think about when they're sort of hesitant about getting a colonoscopy.
Yeah. And it's, important to get it done. So even if you're hesitant, one day of eating clear liquids could save your life in the end,
100%. Yeah. It might be one day of sort of, you're a little bit bothered because, you're going to the bathroom a lot.
Yeah.
But yeah, the importance of getting in there and getting that first screening colonoscopy it's huge. I mean, it's really everything. So.
Right. So now if colorectal cancer is diagnosed, how is it then treated? Like, what are the next steps after you get the diagnosis?
Yeah. So if I do a colonoscopy and I find what I suspect to be colon cancer, what I'm going to do is take a sample of it with essentially like some, they're basically like tweezers. And so I'm getting a tissue sample. The only way to diagnose colon cancer is by taking biopsies. Mm-hmm. I then send those tissue samples to another doctor called a pathologist who's trained to study things under a microscope. And he or she's going to tell us if indeed this is colon cancer. Now, sometimes I'm pretty darn sure that it is colon cancer, just based on the appearance. Mm-hmm. Sometimes biopsies will actually not show colon cancer, but if I suspect that it is, it often is. Sometimes, tissue samples that I take can be very superficial. So if I suspect it's colon cancer, the next step is really to get you to see a cancer doctor. And we have tons of wonderful cancer doctors here at MedStar. I'm going to have you see a colorectal surgeon. And, I have two wonderful colleagues here at the Center for Digestive Disease who, they've done all of their training in colorectal surgery. They're specialists when it comes to colon cancer. So the benefit is that, we quickly get you to see these other doctors and sort of we begin further investigation. One thing that we do right away is we'll get some imaging. So we get a CAT scan that looks at essentially your entire body. So your chest, your abdomen, and your pelvis. The thing to figure out initially with colon cancer is whether it's just localized, meaning whether it exists only in the colon or if it's gone elsewhere, if it's spread to other organs. We see it, for example, commonly at times, colon cancer can go to the liver, it can go to the lungs, it can often spread to what are called lymph nodes that exist close to the colon. So it's really important to figure out, again, if it's just in your colon or if it's gone elsewhere, because that dictates treatment decisions. The only cure for colon cancer that's localized, for a colon cancer that's just in your colon, the only cure for that essentially is to take it out. And that necessitates surgery. So a colorectal surgeon, like my colleagues, they'll go in and they will essentially, they'll cut it out from your colon. And, they can do that in a variety of ways. I'm not going to get into sort of the surgical techniques because that's certainly not my area of expertise. Other ways to treat colon cancer, for example, if it has gone elsewhere, and we call that metastasizing, metastasis is, for example, by receiving chemotherapy. Often chemotherapy will be given before consideration for surgery if the cancer has spread. But those are sort of the things that you're going to talk about extensively with a cancer doctor as well. And understandably, if you're diagnosed with colon cancer, you're going to have a million questions. And so, our job is to answer all of those and, to make you feel as comfortable as you can. And, the decision to undergo surgery or, chemotherapy, if it's needed, it's a team effort. And so at the end of the day, as with everything, we're only going to do it with what the person's comfortable with. And, but that's at least initially how we address it.
Mm-hmm.
And that's how we sort of get the ball rolling as quickly as we can. You'll get some blood work as well, to look for, some tumor markers that can be associated with colon cancer, things like that.
Okay. Well, thank you for explaining that. We did get a couple of questions from our viewers. So thank you for those. Our first one has to do with what we were just talking about before, colonoscopy and being hesitant to get one. They say, I'm terrified to have a colonoscopy. I have a colostomy, which I received in 2007 after spending 5 months in the hospital with a perforated bowel. I have 3 other family members who also suffered from perforated bowels. I know there's always a chance of perforation when a colostomy is performed. What can you say to ease my mind?
Good question. And I understand the hesitation, of course. I would feel the same way. So listen, overall, and this doesn't apply to the individual who's asking the question, but overall perforation is rare. By the numbers, there's a huge study that looked at about 2 million colonoscopies. The rate of perforation, it's thought that perforation occurs about once for every 2,000 procedures. Perforation really varies. Perforation, if it's significant, that basically means that, when a gastroenterologist is performing the procedure, he or she can actually see a hole that has been produced in the colon. Sometimes, though, people will have something called a microscopic perforation, which is microscopic, meaning not, cannot be seen with the eye, and often those heal on their own. But, for this person who's asking a question, if you've had a history of it, of course you're going to be hesitant. And it sounds like that person, which is pretty crazy, but also has family members who've had it as well. Again, it's really uncommon, but anytime a colonoscopy is done, I make sure to be as careful as possible. When we see perforation, it's most commonly seen in the setting of having large polyps taken out, and specifically large polyps that require a lot of use of instruments and make the procedure take a lot longer in terms of duration. When we do a procedure, by necessity, we have to put a certain amount of air into the colon. Your colon is a tube that's usually sort of collapsed on itself. To sort of expand the tube in order to see well, that's why we put air in. More commonly, I use carbon dioxide to do that, which seems to be a little bit safer. But long story short, I try to use as much air, as little air rather, as possible. And we try to be as careful as we can. Some colons, sometimes you see perforation because some colons can be difficult to get through. I remember before I started my training, I thought, well, hey, the colon's just a tube. You should just be able to go through it pretty easily. Mm-hmm. That's not the case. Some people, because of their anatomy, can have, a difficult to navigate colon. And so it requires a lot of, abdominal pressure and sort of a lot of effort. That can increase the risk for perforation. All gastroenterologists are as careful as we can be. What I would tell the person who asked the question, that 100% I understand your concern. Whoever's going to do your procedure, they're going to know your history. They're going to know that, that this has happened to you before. Just the fact that you have the colostomy, I've done colonoscopies many, many times in individuals who have colostomies. And, overall, I don't think that there's much of an increased risk in terms of perforation in that setting. Yeah, I would just say that, I would be careful, as I always am. Listen, at the end of the day, if that person's still hesitant, there are other options. There are other screening options, like we talked about. There's there's the virtual colonoscopy that we talked about. There's, the stool samples. So just to keep those options in mind as well.
Right. Thank you. And thank you for the question. Our next one is from Teresa, and she asked, I have regular screenings every 3 years, and recently a sibling was diagnosed with advanced colon cancer. Should I get screenings more frequently now, or could I use Cologuard tests between screenings?
So I would not use Cologuard, because you're not at average risk. Cologuard is simply meant for those of us who are at average risk. You're not at, the person asking the question is not at average risk because her brother was diagnosed with colon cancer. So you should have a colonoscopy every 5 years, until the age of 75 at least, without fail. So your next colonoscopy, even if you don't have any precancerous polyps that are found, you're going to have one in another 5 years. There's nothing proven at all. There's no need to have that screening procedure more frequently than every 5 years. So that's the answer. Yeah, she should figure out when her last one was done, and then her next procedure should be 5 years from when her last colonoscopy was done.
Okay, great. Well, thank you for answering that. And once again, thank you for the question. So to kind of wrap this all up, my last question for you is, what is the message you want our viewers to receive from watching today?
My message would be just to stress the importance of screening colonoscopy. It's very important. Again, colon cancer typically doesn't give symptoms until it's really advanced. And so, the benefit of a screening colonoscopy is to get a really close look at your colon, to find precancerous polyps if you happen to have them. You're typically going to have no idea if you have precancerous polyps or not, because they usually do not cause any symptoms. If I find precancerous polyps, I take them out right there. And so, the benefit of a colonoscopy is it's the only method that allows me to see your colon close up. And if there's anything abnormal, I deal with it right then and there. If I take out a precancerous polyp, it's taking away the chance that precancerous polyp had to maybe one day turn into colon cancer, which is unbelievably beneficial. The takeaway too, though, is that screening of any kind is really important. If someone out there just is adamant about not wanting a colonoscopy, so be it. We're all different, but at the least, I want that person to get Cologuard, or to submit a stool sample, to get a virtual colonoscopy, something. I really want people to investigate their family history. It's not unusual to not really know much, whether an immediate family member has had colon cancer. But investigating that is important. I want people to figure out if they think that they possibly could be at increased risk. And if they figure out that they are, or if they're suspicious that they might be, to talk to me about it, and we can figure it out. There are reasons to get a screening colonoscopy before age 45. And we talked about that. I also just want people to realize that that's the new recommendation, is to start this screening at age 45. For African Americans, it's always been at age 45, but now that's true for really everyone. And, for those of us out there who have not been screened before, it's never too late. If you're 55 and you've never had one, I don't want you to be like, well, I've never had one, I'm good. That's not right. You need to have a screening colonoscopy, even if you're 75, if you've never had one. The point is coming in, talking about it. I think some people are hesitant, of course, understandably, because of the pandemic. And so a lot of people, they're afraid about getting sick. They don't want to leave their house. If need be, I'm always happy to talk to someone, just as we're talking now, by video. I could talk to someone over the phone. A lot of times I don't necessarily have to see you face to face If you're a generally healthy person, a lot of times we can just talk over the phone and we can schedule the colonoscopy that way. That's no effort on your part. It's really easy. So yeah, my takeaway is just to really be proactive about getting screened, to not be scared about it, to not be scared about the procedure, about colonoscopy. For the huge majority of us, it's really seamless. It's quick overall. Typically takes about 30 minutes, and you usually feel just fine afterwards. So that's the long-winded, big sort of takeaway.
Well, I think that was a perfect summary for, what the message we're trying to get out there with this. So with that wraps up our broadcast. Thank you again so much, Dr. McMullen, for joining us. We really appreciate it. And thanks to all our viewers for tuning in and sharing your questions. For more information or to schedule an appointment, you can call 443-777-2475. Thank you again, and we'll see you next time.
Thanks, everyone.